Hi, welcome to You and Your Health. I'm your host, David Bertone. Today we're going to talk about two common problems that occur both to the head area. The first is something that's in the news on a daily basis affecting many athletes across America, and that's concussion syndromes. After that, we'll go into a discussion about something that millions of Americans suffer on a daily basis, and that is headaches. To talk about these topics, we have a board-certified neurologist today, Dr. Tommasina Papa-Rugino. Thanks for joining us today.
Thank you.
And we're going to explore these topics in great detail. Thanks for joining us. So tell us a little bit about your background and how you got into neurology.
Well, as you say, I'm a board-certified neurologist. I got into neurology, actually, because I always think of the brain as sort of an organ where you can, by physical symptoms, you sort of have to figure out where in the brain there's certain lesions. So I've always, it's sort of like being a detective. And so that's how I got to neurology. I did my medical school in New York at SUNY Downstate in Brooklyn. I did a residency at UMD&J in Newark. And then since then, I've been either in private practice or with a medical center.
Great. And where are you practicing now?
Right now, I'm affiliated with Southern Ocean Medical Center in Manahawkin.
Okay.
And I'm the neurology. It's a private practice, but it's affiliated with the hospital.
Great. Now, I'm assuming you see quite a bit of headaches and concussions throughout your day, along with many different other diagnoses.
Well, my subspecialty is actually headache medicine.
Great.
So I do see a lot of that.
Excellent. We're going to talk about the concussions first because that is in the news on a daily basis. And people are just looking at all different areas for information on this area, in this problem, on how they could, number one, detect problems, especially in their young children, and what they can do to prevent these problems from really becoming a major issue because we're seeing it more frequently in the news. Can you just talk briefly about what really is a concussion and what's happening?
Well, and this is where the problem comes, in defining some of these things, because there's a lot of definitions. And over the years, there's been a lot of definitions of concussions, definitions of symptoms, and as far as guidelines to, go back to whatever sport or activity you were doing. In the simplest terms, a concussion is a mild brain injury that can occur on impact or with any other type of trauma. But usually it implies a strike of the head. Concussion just implies some sort of strike or violent effect to any organ, and in this case, the brain.
Okay. And is there usually some kind of acceleration that occurs inside the skull?
The majority of the injuries occur because the brain and the skull actually are moving at different speed. So what happens is that the skull hits, then the brain follows, and you get what's called a coup contra coup. In other words, the part of the brain is going with the site of the injury, and then it bounces back and has an injury on the opposite side.
Okay. Now, is there trauma directly to the brain typically, or is it just more because of the acceleration?
Well, that's where the issue comes also because that's something that we're trying to understand, where exactly is the injury. We know that if we do imaging studies like a CAT scan or even an MRI, we don't see any evidence of injury. So what we're beginning to understand is that maybe it's a cellular injury, an injury to the smallest part of the brain, or maybe some sort of biochemical changes that occur subsequently to cellular damage. But if you're looking for bigger evidence of injury, you're not going to find it.
Okay. Now, what should people look for?
Well, there's a couple of symptoms that you can look at. The simplest one, of course, is confusion. Someone hits their head and they have some confusion immediately afterwards, either some difficulty with remembering what happened or even a difficulty with orientation. In addition to that, you have things like dizziness, blurred vision, difficulty with balance. Subsequently to that, you can have even more severe cognitive problems, difficulty with sleep, and of course the ultimate damage, the what we call the highest level of concussion, will be loss of consciousness, trauma, visible trauma to the brain. But the simplest thing is really cognition. Someone is confused, just briefly confused as to what happened or what is going on. and difficulty with balance.
Now, quite often in the past, people were told after there was some kind of a head trauma, be watched while you're sleeping. Or watch for nausea, things like that.
Well, right. There's, of course you can have headaches, you can have nausea, you can have all of that. But, what they were looking for is seizures, during sleep. That usually does not occur unless you have really severe trauma. Seizures and mild head trauma do not occur as often. The other thing, watching during sleep, I guess some of the people were concerned about progression of symptoms and maybe even further loss of consciousness or further evidence of injury.
Now, when should someone seek medical attention? I mean, is there any, every time there's a head trauma, or is there certain signs and symptoms where they really need to seek the advice of a physician?
The guidelines are different, but now they're becoming more and more stringent. The problem is we're looking at high school students who are playing these sports, college students, and what we actually suggest is that all these children or young adults who are playing sports be evaluated immediately after, even if it's, a brief spell of confusion. We're actually suggesting that certain times that we get even screening of these patients, that maybe these patients may require what we call neuropsychological evaluation, and then afterward on a yearly basis get subsequent to see if there's any progression or any change in their symptoms. But actually what we're suggesting right now is that somebody should be evaluated right away. The problem with that, and what we're beginning to also understand, is that we're missing a lot of these traumas because, you have these teenage kids who are playing, they're getting up, let's say a football player. They're playing, they're in the bottom of a heap, they get up and they shake it off, not realizing some of their symptoms. Interestingly enough, the younger the brain, the more severe the concussion seems to be. The older the brain, like a football player, like an NFL football player, they can get hit and continue the game. A younger patient, on the other hand, or a younger football player, may, with the same amount of trauma, actually have more symptoms, more of a loss of balance, more of a ringing in the ears, more of a little bit of a headache. The different definition of concussions and the different levels, whether it be the earliest, the simple levels, or the more difficult levels, basically gives you a period of 15-30 minutes of leeway. If you have some difficulty with confusion or some symptoms for less than 15 minutes, that's more benign than if your symptoms persist a little bit longer.
So it's transient. If it's
all
quick
transient.
And it goes, and then it'll be okay.
It's
but
all
if it's
transient.
lingering, okay.
But what we say, even nowadays, we're beginning to realize that even the transient short one may have long-term effects, particularly if they're repetitive. You have a second concussion on top of a first concussion. Even if you have recovered from some of those symptoms that you had initially, after a second concussion, they may come back and be a lot more severe. And if your symptoms have not resolved, then you have more than the additive effect. You can actually have more severe findings.
Okay.
That is why we're beginning to try to ask for guidelines. As you know, there are no guidelines. Only about 6 states, which New Jersey is not one of them, have some guidelines as far as what to do with minor head injuries in football players or high school sports. But we don't have national guidelines. So you can have a small injury and you can go right in some places. The coach may send you right back, or you can have a small injury or brief injury and be out for about 7 days to 2 weeks. We actually suggest that, particularly in high schoolers, that they actually, no matter how minor the head trauma is, a lot of us are beginning to suggest that they do not return to the game at all immediately.
Okay.
And if they have symptoms, then they certainly, need to be evaluated, 7 days to 2 weeks to 3 weeks later. And they also need to be evaluated with exertion so that, your symptoms can go away. Whatever difficulty with balance or headaches or whatever you had can go away. But as soon as you start doing some activity or to go to the vigorous training back to your team, your symptoms may come back, in which case you go back to being off the field.
You talked a little bit about the screenings, and I'm starting to see that more in my practice, and and this neuropsychological testing. One of the brands is Impact, where you're really testing their cognition and balance before injury occurs. So set the baseline, and that way you can see after, when there's injury, if there's been some cognitive change and balance change. That seems to be the trend.
That's the trend, and what you're going to see is probably you're going to have some of this testing done before a child enters whatever sport he's going to enter, and then maybe done periodically, a year later, and then a year after that, because as I said, cumulative effects will show up a year or 2 years later. And it's not just cognition. Even behavior has been associated with multiple concussion, and nowadays depression. You have some not just cognitive complaints, but psychological complaints with people who have repetitive head injury. So the beauty about the neuropsychological testing is that it looks at both things. It looks at the cognition and the behavior. And so I think they will become standard to probably do these on a regular basis, particularly the younger the child is, or as they enter high school and want to play football.
Sure. Now, is there any treatment, or is it just rest? Is it really avoiding activity?
Right. The majority of treatment just basically centers around resting. And not doing any type of activity. If you have things like difficulty with sleep or headaches, I mean, you can do you can treat in that way. But that is just symptomatic treatment.
Okay.
The mainstream treatment is just rest, and that's what you have to do.
It's not like a typical body part.
No,
you put ice
it's not
on
like
it
I can
or
put a
something.
stitch or something, and I can say, here you go, you're all healed.
Sure.
And that's what becomes difficult, because, you have a 17, 18-year-old or whatever, and they're like 2 weeks away from a major game or a major tournament, and they come in and they've just hit their head, and, and you're there saying, you're still having headaches, you're still off balance, I don't want you to go back to play. And they look at you like, like, what are you talking about,
Yeah.
Sometimes even parents,
Well, that's the
can
danger.
give you a hard time.
Yeah.
They go, oh, but, I want my son to go into this great, game that they're playing next week or whatever. And, they have to be made aware of that. You cannot rush someone who has been hit on the head back into the sport that they were doing.
I think that is the one good thing about the publicity that's happening, is that parents are becoming more aware of it. Not only the signs and symptoms, but the dangers, and they are at least considering it more, and not pushing the kids, which are helpful.
And before we're thinking, for example, that the dangers were with significant head trauma. We always knew that patients who were boxers, for example, and had significant trauma, they develop neurological complications, like Muhammad Ali and and his Parkinson's disease. But now we're beginning to understand that the younger brain actually does worse, and you don't have to have severe trauma. You can have just mild symptoms, and repetitive mild symptoms can lead to severe symptoms in the future. That is why prevention is also very important. And one of the things that we're looking at, of course, is the shape of the helmets and how to get, better headgear, whether it's on a sport or whether it's recreational, bicycling or football or whatever. Because if you can prevent that impact, and you can prevent that, sort of shaking of the brain within the skull, then you can prevent some of those symptoms.
Great. So that's a good transition. When we come back, we're going to talk about headaches, the typical common headache that people have on a daily basis, and we'll return right after this.
My name is Amanda. I'm 21 years old. I have lots of friends that use tanning beds that lay out in the sun all the time, and I tell them about Jamie. Jamie was in her early 20s when she was diagnosed with melanoma, and she died right before she turned 30. Jamie's death caused me to stop tanning completely. Before that, in high school, I wanted to be dark and look good in a prom dress or a bathing suit. In high school, it was the thing to do. But after Jamie's death, I completely stepped away from tanning beds and never went back. I know now tanning can cause the worst possible skin cancer you could get. People think tanning is safe. I don't think it's safe. you could die just like Jamie did.
This message is brought to you by the American Academy of Dermatology.
Welcome back to You and Your Health. I'm your host, David Bertone. We're here today with Dr. Papa-Rugino, who's a board-certified neurologist, talking about concussion syndromes and headaches. Dr. Papa-Rugino, thanks again for joining us.
Thank you.
So we're going to transition now into the headache. And if you can just review for the audience, what is a common headache like? What are we talking about?
Well, the majority of patients who go to a neurologist, their complaints is usually headaches. We have different definition of headaches. The simplest would be simply head pain, any pain, in the head. But the American Headache Society has so many different classification of headaches. The major headaches being migraine headaches and muscular tension headaches. The severe headaches that we see are usually migraines. Okay. And in order for you to have migraines, you have to fit a certain criteria. The criteria is you have to have either unilateral pain, throbbing in nature, moderate to severe in intensity, and increases with movement. For example, if you're exercising or going upstairs, your head pain gets worse. In addition to that, you need to have either nausea or light or sound sensitivity. And those are what we define as migraine. Musculoskeletal headaches or tension headaches are less severe. They're usually bilateral. They usually don't have associated nausea, vomiting, light sensitivity, sound sensitivity. And then you have a variation of other headaches, which, are a little bit rarer, but they're basically more different location. They can have other different associated symptoms like tearing of the eye, nasal discharges. And then you have cervicogenic or occipital headaches, which are caused, for example, by cervical or disc pathology in the neck, which then spreads upward. But the majority of headaches are migraines.
Now, what do you use from a diagnostic standpoint? Is it really just the symptoms, or do you do some special testing to help determine?
It's mostly the symptoms. As I said, you have to fit that criteria. You have to have recurrent headaches. And basically, it's just a diagnosis by criteria, by symptoms. There are no imaging studies that you can do that tells you, yes, this patient is having a headache. All the CAT scans and MRIs that we do are usually normal. We do obtain studies just to rule out the possibility of these headaches being secondary to something like aneurysm, brain tumors. But the majority, 99.9% of headaches, usually we don't find anything in the MRIs. We also do some routine blood work. But everything is normal. And people come back and say, well, why do I have these headaches if there's nothing there in the studies? Usually it's because you have a genetic predisposition. Someone in your family has to have had headaches at one time, or unfortunately you're the first one in your family. Family history has to start somewhere. And then there's certain triggers. For example, with migraines, women have more migraines than men. So there's sometimes the menstrual cycle or hormones can be a trigger. In certain other patients, it's stress. Sometimes it's food, certain drinks, and caffeine. Caffeine is one of the most common triggers because it's the caffeine withdrawals that actually is what's giving you headaches. Mm-hmm. What we think is actually causing the headaches and why we don't find anything on the imaging studies that we do is because probably migraine headaches are a combination of vascular changes that occur in the brain and chemical or neurotransmitter changes that occur in particular parts of the brain.
So when you talk about vascular, that's a blood flow issue.
It's a blood vessel. Blood vessel that dilate or constrict.
Do you see any other problems that a patient might have may increase their risk of something like migraines, either diabetes or alcoholism or smoking?
Well, of course, a lot of time, if any patients that has any unhealthy lifestyles, for example, lack of sleep, lack of proper diet, increased weight, as you mentioned, smoking, that will increase your chances of getting certain types of headaches. But the majority of headaches, you do have to have a genetic predisposition for it.
Okay. Obviously, in my practice as a physical therapist, I see a lot of the tension headaches, a lot of the cervical based headaches that refer pain to the base of the skull. And you say those are typically have to be bilateral on both sides of the head, where the migraine is usually on one side.
Correct. Musculoskeletal headaches are usually, bilaterally, while migraines are usually unilateral. But having said usually doesn't mean all.
Sure.
You have a lot of, migraineurs, so patients who have migraines, who will complain of generalized throbbing pain or pain in the occipital part or the neck part of their bodies, in addition to this throbbing pain that they have.
One of the things that when I treat these patients is the postural component. When they have this muscular skeletal problem, is I see so many people with forward head postures and at the computer all day and the way they drive. It puts so much strain on the nerves at the base of the head. Is that a common thing that you see as well?
I mean, you see people who spend a lot of time on their computers, driving. They do have an increased incidence of tension headaches, musculoskeletal headaches. Simply because, unfortunately, their job or some of the activities that they're doing. Sometimes they hold their head in a certain way and, they don't relax or they don't do any, movements, and that can lead to musculoskeletal issues.
All right, let's talk about some of the treatment options for things like migraines first. I know there's drugs out all the time. What are the studies showing as the most effective treatment for migraine?
The most effective treatment is the triptans, what we call the triptans. This is a class of medicines. The first one that came out was Imitrex. There's about 7 or 8 of them, and they're the most effective ones as opposed to narcotics. Years ago, when patients used to go to the emergency room with severe headaches, the first thing they used to get was things like Percocets or Fioricets. And now what we've found is that actually the chronic use of these medications will transform your headaches into even more severe headaches. So what we actually recommend, if unless you have some contraindication, is a drug like the triptans, which works on the blood vessels that I mentioned before. The other thing that you have to remember is that migraines are recurrent. So if you have more than 4 or 5 headache days per month, we actually suggest that you use something to prevent these headaches. And a lot of times the medication that we use usually belong in different categories. For example, Topamax or Elavil. These are either anti-seizure medicine or old anti-anxiety medicines, which have been proven to work effectively in the prevention of these headaches.
So you would use those throughout, like on a daily basis, and then use the migraine medication during an actual headache?
Correct, at the onset of the headaches. And when I say at the onset, I mean at the onset. Unfortunately, migraineurs wait. They want to see if the headaches goes away, if this is, quote, a real migraine. And what happens is the more time goes on and the headache continues, and then you decide to take something, a lot of time that cuts down on the effectiveness of these medication.
So it's getting it early, get the medication in early, and then that can reduce the symptoms at that point.
Correct. Now this is for adults. We would treat children differently. I mean, the same headaches that occur in adults can occur in children.
So you see migraines in children?
Yeah, we see migraines in children. In fact, a lot of times migraines can present differently in children. Sometimes it's sort of hard to get them to complain of head pain. A lot of times they can have cyclic vomiting, like, vomiting from a week to another week to another week. And a lot of those cyclic vomiting children are actually migraineurs in the future, and they just don't know how to express their symptoms. Any headache in young children, we suggest, gets properly evaluated by a neurologist.
Okay. And let's talk about the common headache, the more tension headache. What are the treatment options for that?
Well, some of them, again, if they occur fairly frequently, we again suggest something preventive. The preventive agents change a little bit. We may suggest more of muscle relaxants, for example, that you would take on a nightly basis. We also suggest things like exercise, biofeedback, relaxation techniques, which I'm sure you're very familiar with those. And that's what we usually suggest.
So it's not just a drug option. You can look at some other things.
We look at other things. I mean, even with migraines, there's certain things that we suggest, like vitamin supplementation, magnesium supplementation, which may work quite well rather than initially simply go to a drug. A lot of it depends on the frequency of your headache. And some of the triggers. I mean, if you can even eliminate some of the triggers, or if you can do some of those non-pharmacological treatments, sometimes that can help with the headaches without having to go to daily medicines.
Now, some people have triggers that are like nitrates and other chemicals.
Yeah, that's
right?
like in the foods, a lot of it. Even like things like red wine or alcohol. And, after a while, you become sort of in tune to what your triggers are. The major mistake sometimes that people make with migraines is those patients that come in thinking that they have chronic sinus headaches.
Okay.
Those are usually chronic sinus headaches are very rare. What those patients usually have is chronic migraines. It's just something environmentally or allergic-wise that's their trigger that makes them believe that they have sinus headaches. Sinus headaches usually occur in the setting of an acute infection. Some purulent discharge, clogged sinuses,
and that
fevers.
would be more of a frontal headache?
Exactly. That's usually more frontal. And you really are sick. I mean, you look sick, your coworkers tell you to go home.
You have a fever.
You have a fever, and that's usually is what sinusitis or sinus headaches really are. But for patients who have chronic headaches and to say that they have chronic sinus headaches, it's unlikely. The majority of those patients, if you really look at what their symptoms are, they will fit into the criteria of migraines.
I've seen that before, where patients come in and it's just continuous, and then they're just constantly put on antibiotics. And it's
nasal
just
sprays,
or
things like that.
Yeah, the influence of the allergy season and
right.
all that affecting
a lot
the
of that,
headaches.
a lot of that is on migraines. It just happens to be cyclical, and it may happen at a particular time of the year, which you find in migraineurs. One of the things to remember about migraines are a lifelong illness. I mean, they may go away for a little while, but then they will come back. And certain, nothing has to particularly trigger them to come back. And sometimes they go away on their own, or you have to have a therapeutic intervention to make them go away.
So there's no cure for migraines?
There is no cure. As I said, it's pretty much of a lifelong illness. I mean, they can, in women particularly, if there's some hormonal influence, they can go away post-menopause. But there's a lot of women postmenopausal who still will have migraines.
Sure.
In addition to that, there's a small percentage of migraineurs who, no matter what you do, what preventive agent you use or acute agents you use, the headaches become very difficult to treat.
What about the influence of things like caffeine and alcohol? How do they affect
It is actually, as I mentioned before, caffeine, we know, as particularly caffeine withdrawal, is one of the things that triggers migraines.
Okay.
And what we usually ask migraineurs is to decaffeinate themselves. Caffeine has no taste. So, some people say, oh, but I know the difference between caffeinated and decaffeinated coffee. But caffeine has no taste. So we actually ask migraineurs to decaffeinate themselves. If you know some of the over-the-counter medication, they have caffeine in them because it is caffeine withdrawal that, that's leading to headaches. And so, we figure, well, if we give them a strong cup of coffee or a pill that has caffeine in it, that will treat it that way.
Interesting. Well, thank you so much for joining us.
Thank you.
I really appreciate it. You heard today about concussion syndromes and headaches with a board-certified neurologist, Dr. Papa-Rugino. Thanks again for joining us on You and Your Health. I'm your host, David Bertone.